Hi, my name is Anthony Rivas. I'm a professor of medicine at UCLA and I treat patients with metastatic melanoma. Today we're here because there's a new relevant clinical data from a clinical trial that have been reported in the New England Journal of Medicine, which is a phase 1 to 2 study of a combination of a BRAF and a MEK inhibitor. For the past 10 years, we learned that around 50% of melanomas are driven by a mutation called the BRAF mutation. That is like an on-off switch that should be that regulates cell cycle and cell proliferation. And in melanoma, it gets stuck on the on position in around 50% of the patients that have a particular mutation called BRAF B600E. That is telling the cancer cell to behave like a cancer and be growing uncontrolled, in an uncontrolled fashion. In the last 5 years, there's been inhibitors to BRAF that have been developed, and the one that has gone farthest along was first called PLX4032 and then was called bemurafenib, and now is FDA approved since last year with the commercial name of Zelboraf. And it's a specific BRAF inhibitor that leads to high response rate in these patients with this mutation. The biggest drawback has been that the tumor eventually finds a way around this blockade of the driver oncogene, and in the majority of cases, it will regrow within months from the initial response. So there's been a lot of interest to understand the molecular mechanisms of how melanoma can first respond and then start growing in the presence of the BRAF inhibitor, and then how to overcome this with combinatorial therapies. So the two biggest limitations of using bemurafenib or the other BRAF inhibitor that's been in clinical development, the brafenib, that we'll talk more about today, has been twofold. The resistant mechanism, the development of resistance to these therapies is the most important one, where understanding what allows the tumor to regrow may lead to understanding how can we get a better initial response and how can we prevent resistance, the development of resistance. The second one has been something that was not anticipated with this drug development, which is that BRAF inhibitors have a dramatically different effect on a cell that has a mutation on BRAF, like the melanoma cancer cell, and cells that have other mutations, in particular mutations upstream of BRAF, in particular in RAS and HRAS. In the situation where there's a mutation right on top of BRAF in RAS, the cell that has that mutation and we use a BRAF inhibitor, instead of blocking the signaling through the pathway, it actually transactivates the pathway in something that's it's known as the paradox of BRAF inhibitors and paradoxical activation of this pathway. That is the molecular basis for the development of secondary squamous cell carcinomas, which appear in around 1/4 of patients who are treated with single-agent BRAF inhibitors. We know pretty well why the majority of melanomas become resistant to single-agent BRAF inhibitors, and that's by reactivation of the same pathway and signaling through something to a molecule downstream that's called MEK. But also, we know that the paradoxical activation that leads to the squamous cells or the side effects of the BRAF inhibitors can also be blocked because they go through MEK. So the concept was that if we give a BRAF and a MEK inhibitor together, we may be able to get a better initial response, a more durable response because it would delay some of the mechanisms of resistance and also decrease the side effects. So that is something that I think there's very few precedents in medicine where we combine two agents in a rational way. We understand the molecular biology of it, we understand the signaling, and it will lead to better responses and less side effects. So there's been now 2 phase 1 trials that are being developed to combine the BRAF and a MEK inhibitor. The first one was reported at ASCO this year by Jeffrey Weber, an investigator at Moffitt Cancer Center, and a group of investigators working with dabrafenib and trametinib. Dabrafenib being a highly selective BRAF inhibitor, and trametinib being a very promising MEK inhibitor. Both of these agents, when used as single agents, they have benefits in patients with BRAF mutant melanoma. They both block the oncogenic signaling. And when they were put together in this phase 1 trial, the conclusion was that it was feasible to put them together. There was the side effects were manageable, and actually they seemed to be lower than either agent by itself. And there was promising early evidence that it could have more to be more efficacious. But that was based on a phase 1 trial which had a number of patients entered in different cohorts, but obviously was very far from being definitive data. So the data that just came out in the New England Journal of Medicine manuscript is a combination of the phase 1 dose escalation cohorts of this clinical trial combining dabrafenib and trametinib, the BRAF and the MEK inhibitor, with a small phase 2 randomized trial. And a phase 2 randomized trial is obviously underpowered and doesn't have enough numbers in each arm to give definitive information. This was based on a study of 162 patients that were allocated, half of them to receive the dabrafenib alone and the other half to receive the dabrafenib plus trametinib. And the data is highly in favor of the combination, but it's obviously not the final. It doesn't define as a new paradigm of therapy, and it would not be enough to gain regulatory approvals. So there's already 2 randomized clinical trials with the same 2 combination, with this combination being tested against the BRAF inhibitor alone. Yes, in the data that we had from the single agent study, the single arm studies from the phase 1 suggested that the incidence of squamous cell carcinomas that with the dabrafenib has been around 15 to 20% would go down to 1% or less. That was based on a cohort of patients that were not too large and hadn't been followed too long. With this new data that we have a larger group of patients in both arms, we're seeing that the benefits of the combination does decrease, that the combination does decrease the incidence of squamous cell carcinomas, but it doesn't make it disappear completely. It may be that we're more aware about these agents, that we diagnosed them earlier. It may be that the incidence doesn't change that much, but they're less aggressive or they're less prominent. We don't know. There's much more that we need to learn from this. I think it does demonstrate that there is decreased incidence, but it's not. They still can develop. So what's being reported is a combination developed by GSK, by GlaxoSmithKline, with their 2 agents, the dabrafenib and trametinib. Very early on, GSK that was behind on the drug development of BRAF inhibitors compared to Roche Genentech with melanoma. They made these assumptions that putting the drugs together may work better, and that was based on very solid preclinical data that's now translating into patient benefit, or at least early evidence of patient benefit. Roche Genentech has also been developing such a clinical trial, and actually was presented on the same session at the ESMO meeting, with having reached the recommended phase 2 dosing regimen of combining dabrafenib and a MEK inhibitor from Genentech, GDC. This combination will also now move quickly to phase 3 randomized trials, so we'll have 2 companies, GSK and Roche Genentech, developing a series of randomized clinical trials trying to demonstrate that the combination of a BRAF and a MEK inhibitor is more efficacious and has manageable side effects compared to a BRAF inhibitor alone. The development of this combination of BRAF plus MEK inhibitors is a step forward in oncogene-targeted therapy with a combinatorial therapy to improve efficacy and decrease side effects, or at least that's the early data. The improved efficacy in the clinical trial that is out today is based on a 60% decrease in the rate of progression with the combination compared to the single-agent BRAF inhibitor. If we consider how we have moved with the BRAF inhibitors that had at least another 60% improvement in progression-free survival and overall survival compared to our older standards from just a couple of years ago, like the carbazine, a chemotherapy agent, it tells us that in a very short period of time, we've significantly moved forward the treatment of this disease. This is only relevant in the 50% of patients that have this particular mutation, the BRAF V600 mutation. And so far, the majority of the data suggests that even with the combination therapy, where we're anticipating some of the mechanisms of resistance and preventing them by giving the MEK inhibitor together, that the melanoma eventually still finds a way around it. It will take longer, so we've gone from progression-free survivals of 2 to 3 months with anything we had tried in melanoma the past 30 to 40 years, to progression-free survival of 7 to 8 months with the BRAF inhibitors alone, to progression-free survival of 9 to 10 months. I'm sorry, I made a mistake. It's all in months, so it's 6 to 7 months with the BRAF inhibitor, and then 9 to 10 months with the early data we're having with the combination of a BRAF and a MEK inhibitor. So progression-free survival is moving along. Overall survival in these groups of patients is also dramatically shifting to an improved overall survival. And a disease that we used to have a median overall survival of 6 to 9 months, now with BRAF inhibitors, we'll have it consistent between 13 and 16 months, and we'll have to see what the future will tell us with the combination of a BRAF plus a MEK inhibitor. But still, this is not a cure to melanoma. It's demonstrating that we can really cripple the cancer and hit it with drugs that hit hard where it hurts. But we have to go one step further and be able to anticipate all of the resistance mechanisms to turn these into a chronic disease or a highly treatable cancer.